Hi all, myself Dr. Selva Kumar, reader from Department of Maxillofacial Surgery, SRM Dental College. This topic is about free fibula harvest, a cadaveric dissection. Coming to the indication of the fibula is if there is an extensive defect of the mandible, total and subtotal reconstruction, mandibular reconstruction, and maxillary defects. And if you have a composite defects like osteocutaneous version, including a skin paddle, you can use a fibula flap. Next is ramus and condyle reconstruction. You can also provide two separate skin paddle for closing the perforating defects of the cheek while simultaneously reconstruction of the bone and extremity defects like tibia and fibula. Advantages of the fibula being it's a longest bone available, maximum up to 25 centimeter. You can provide excellent stability for dental implants to allow for a two-team surgical approach. The advantage of the fibula is you can do a multiple osteotomy in the shape of the mandible and immediate reconstruction with immediate implant placement. It gives the high initial stability. You can also use the fibula with the double barrel technique to increase the height of the bone. The disadvantages of the fibula is the height of the fibula. Since the height of the fibula is very less, it has got a very limited vertical height. So you can use a double barrel to increase the height. Next is the vascular and anatomical risk. Sometimes the vascular anatomy um, um, is not um, clear always. So you can have a altered vascular anatomy, and the skin parallel is not reliable. The skin perforators can be in different sources, and donor site morbidity and pitfalls as usual, and surgical and aesthetic limitations are the disadvantages we have. Now coming to vascular anatomy, the fibula is supplied by the peroneal artery, which is the dominant vascular pedicle of the fibula flap. We have different um, arterial structures. Sometimes the peroneal artery can branch out from the posterior tibial, or it can be a single peroneal artery from the main trunk, or you can have a um, only separate branch from the popliteal artery are called the peroneus magnus. So it is ideal to take investigation like MRI for a CT scan angio for assessing the vascular pedicle, and there is a chance of ischemic risk and atherosclerosis. Fibula harvesting steps. So we start with the initial incision with the skin barrel, identifying the perforator, then the deeper dissection to enter into the flexor spaces, followed by medial and distal osteotomies. Then we do anterior and the medial dissection, followed by identification of the identify the pedicle and ligation of the pedicle, followed by posterior release. And then final step is the elevation of the osteocutaneous flap and closure. This is the landmarks for harvest of the fibula, a line drawn from the lateral aspect of the head of the condyle to the malleolus, which represents the intermuscular septum, and the skin parallel, which is in the shape of oval, which is marked between the uh, middle and the lower one third of the fibula. The skin flap is raised to expose the peroneal muscles. This is the complete dissection of the harvest of the fibula, which shows the osteotomized fibula along with the skin parallel. I will show you the dissection video in the next slide. Okay, this is the cadaveric dissection of the fibula in the right leg. So initially we start with the skin paddle after anatomical landmarks which is marked. Um, once the skin paddle is identified, then uh, uh, once the perforator is identified, then you start dissecting with the lateral aspect of the leg, elevating the peroneus muscles. So this is the peroneus longus, which is elevated from the fibula, leaving the periosteum and the cuff of the muscle. So now what you see is the lateral aspect of the fibula, which is being shown in the hand. So once the lateral aspect of fibula is raised, you start with the medial osteotomy. Go enter into the flexor compartments of the leg, then go dissecting the medial compartment. So then you can dissect the posterior aspect to release the soleus and the gastrocnemius. The posterior skin paddle is posterior incision is made and skin paddle is islanded with the perforator intact. So now you can see the perforators with the skin paddle. So be careful not to cross the perforator region. So sometimes um, you can transect the perforators. So in this step, you can in a live situation you can encounter some bleeding and some perforators from the soleus muscle to the skin flap. Then dissection is carried out in a deeper plane. So here the posterior aspect of the fibula is being elevated off the bone. So once the posterior surface is elevated, then the osteotomy is done. So the periosteal pocket is created in the proximal distal region, which is the medial structures are preserved using a periosteal elevator, and the osteotomy is performed either with a saw or a bar. So medial osteotomy is marked 8 centimeters from the knee joint, and the distal osteotomy is also marked 8 centimeter, 6 to 8 centimeters from the ankle joint, leaving the knee joint and the main perforators intact. So this is the osteotomy of the fibula done with the burr. So then starts the medial dissection. So you can see the extensor compartments. Then we can enter into the middle compartment, exposing the interosseous membrane. So that structure is the sural nerve. So then dissection is carried out for the distal osteotomy. So periosteal pocket is created, elevating the periosteum. See that there is a medial, not to damage the vessels in the medial aspect. Once the osteotomy is completed, then a bone hook is used to hold the bone, and the fibula is uh, retracted laterally to expose the muscles, and the dissection is started. So this is a medial dissection to expose the tibialis posterior. So once a medial dissection, you can see a chevron shaped muscle is the posterior tibialis, the pedicle or the peroneus muscle, which is in between the posterior tibialis and the flexor hallucis longus. So once the posterior tibialis identified, uh, you can use a blunt dissection to identify the pedicle and release the pedicle from the posterior aspect. So identifying the vascular pedicle, so you can dissect deeper to identify the pedicle of the fibula. So this is the posterior tibialis which is dissected, the finger dissection. Then comes the view is the peroneal vessel. So in live situation you can encounter some bleeding, then you can use a bipolar cautery to cauterize the muscle, and then once the pedicle is identified you can start dissecting. Usually we dissect or we transect the pedicle at the distal end, and then we move in a upward direction. Since it's a direct dissection, we want to expose the pedicle. So what you see in the finger is the pedicle along with the peroneal artery along with its vena competens. Yeah, the distal end is started ligating. So once the distal end is identified, we ligate it, suture ligate it separately. And this is the distal end of the peroneal artery and peroneal vessels. So once the posterior tibial is dissected, then the flap is dissected from the FHL or the flexor hallucis longus. Now you can clearly see the flap coming into the view. Yeah, now the distal end is clamped, ligated. In the medial dissection of the flexor hallucis longus is started, the fibula is rotated laterally. Once the deeper dissection is done, you can see the posterior tibial vessels giving branch of the peroneal artery entering into the peroneal bone. So these are the cut end of the muscles showing the vascular anatomy. So then the vascular pedicle is skeletonized, suture ligated at the proximal end, then you can sacrifice a part of the bone to increase the pedicle length. So this soft tissue pedicle can be used for either intraoral defects or extraoral defects, or both combination can be used as a chimeric flap for both intraoral and extraoral skin closure. So markings is done to expose the pedicle there. So in live situation, release the tourniquet and then check for the bleeding there. So check for the bone bleeding and the bleeding from the soft tissue flap as well. So once the flap is harvested, then you can achieve hemostasis and close it primarily. The skin panel can be closed with the skin graft with the negative pressure suction drain there, then followed by a plaster cast in the posterior aspect. So this is the steps in the elevation of the fibula. Skin flap is raised, followed by elevation of the peroneus longus, entering into the middle compartment, dissecting the fibula 360 degrees, retracting the fibula, and then harvesting, and then ligating the vessels. So this completes the dissection of the fibular flap. Thank you.